Hey everybody, we are back for number two, respiratory video number two, and we're going to start with some anatomy of the lungs. Notice that we got the two lungs here, protectively encased within the thoracic cage, protected by the ribs and the scapula and the sternum and the clavicles. Notice how the apex of each lung peaks above the clavicle. The base of each lung sits on top of the muscular diaphragm right here. And notice just how much of the thoracic cavity that the lungs are going to occupy. Now, if we take the lungs out and we compare them in these lateral views here, we can see, of course, that the right lung has 3 lobes, a superior, a middle, and an inferior lobe. Whereas the left lung only has 2 lobes. So the left lung only has 2, just a superior and an inferior lobe. And we've got these deep indentations separating the lobes, and these are known as fissures. Our left lung, since it only has 2 lobes, will just have a single fissure, very much at an angle, and so it is called an oblique fissure. Whereas our right lung, with 3 lobes, will have a pair of fissures. The more angled one is the oblique fissure, and then the less angled one is the horizontal fissure. So I got these nice lateral views, and I can see my base, of course, which would be on the diaphragm, as well as my apex, which peaks over my clavicle. I also see an indentation in that left lung called the cardiac notch, and of course, when we see that word, we know that that is for the heart. All right, this is the medial view of the right lung here. And I can still see my trio of lobes. I can still see my fissures, my base and my apex, but now I can see my hilum, that indentation where things are entering and exiting. I see my pulmonary artery. Again, it's a pulmonary artery, and it's weird because it is a deoxygenated artery. And I see a pair of pulmonary veins. Weird that they are oxygenated. And I see my main bronchus as well. So I see all my vessels and airway tubes that are going into my lung at its hilum. Similar situation with the left lung. Again, I've got a main bronchus, pulmonary artery, and pulmonary veins. Again, I see my apex and my base and my inferior and superior lobe with the fissure between them. There is that indentation we saw earlier called the cardiac notch, as well as a whole dented cardiac impression for the heart as well. Okay, fantastic. Let's talk about the bronchi in those lungs. So we know the trach comes down to the mediastinum, and the trachea splits into the 2 main bronchi. A right main bronchus going to the right lung, a left main bronchus going to the left lung. The left main bronchus is a little bit longer and more horizontal because it has to go past the heart, of course. Now my main bronchi, they're going to split to give me lobar bronchi. I will have a pair of lobar bronchi on the left side because there are only 2 lobes there, while I will have 3 lobar bronchi on the right side. Now, lobar bronchi split to give me segmental bronchi. Then segmental bronchi split more and more, giving me smaller and smaller bronchi. And we can see that splitting in this color-coded bronchial tree here, with the main bronchus on the right and on the left, splitting to give me the 3 lobar bronchi, 2 lobar bronchi on the left, multiple segmental bronchi on both sides, then many, many more smaller bronchi branching away. And all the branching, of course, has the purpose of increasing surface area. More surface area is better for exchange. Here I see just another diagram depicting the same thing. There's my trachea, giving me my 2 main bronchi on the left, main bronchus on the left rather, splitting to give me my lobar bronchi on the left. Then this inferior lobar bronchus here, splitting to give me segmental bronchi, which are then splitting to give me smaller and smaller and smaller bronchi. Now, the amount of cartilage will diminish as the bronchi get smaller and smaller. Remember that we have cartilage in the trachea and the bigger bronchi, in all the bronchi rather. We have cartilage to prevent collapse. Now, by the time we run out of cartilage, we are no longer in bronchi. We are in bronchioles. Bronchioles do not have cartilage. They're in less of a danger of collapse, and their muscle is more able to prevent collapse. Now, because of the lack of cartilage and the presence of a relatively high amount of smooth muscle, one of the things bronchioles can do is they can constrict or they can dilate. Now, of course, bronchioles will branch and branch. Now, the final bronchiole we get without any alveoli is called a terminal bronchiole. And then bronchioles with alveoli are called respiratory bronchioles. And all bronchioles and all alveoli lack cartilage. All right, so we've looked at this progression into our lungs a bit. I do see a nice bronchus right here. Another one over here. I know these are bronchi because I see cartilage in their walls. All right, so bronchioles, as we said a moment ago, lack cartilage. They have a diameter of less than 1 millimeter. There are multiple bronchioles, but we specifically have to know the names of 2 bronchioles, respiratory and terminal bronchioles. Respiratory bronchioles contain alveoli, the little air sacs where gas exchange happens. A terminal bronchiole is the last bronchiole before we get a respiratory bronchiole. And terminal bronchiole, the word terminal means end because we are at the end of the conducting zone. Because when we get into respiratory bronchioles, we are beginning the respiratory or the exchange zone. And our respiratory or exchange zone begins with respiratory bronchioles. So like this is a respiratory bronchiole right up here. Notice it has a lonely alveolus. I've got some more respiratory bronchioles right here with some lonely alveoli, simple cuboidal epithelium in between them. Respiratory bronchioles lead to alveolar ducts, a tube made primarily of side-by-side alveoli is an alveolar duct. Alveolar ducts are going to dead end into these alveolar sacs, these clusters of alveoli. And all of these alveoli containing things constitute my respiratory or my exchange zone. Because it is in these alveoli that I do my gas exchange between the air in my lungs and the plasma in my capillaries. All right, here I see a nice bronchiole here. Terminal bronchiole leading onward to a respiratory bronchiole, leading onward to an alveolar duct. So always good to put the real histology with it, although it never looks quite as nice as the picture. Okay, alveoli. We have them in our respiratory bronchioles. We also have them arranged into ducts and sacs. And alveoli are numerous. There are about 300 million of them in the lungs. This is an alveolus right over here, made of simple squamous epithelium. And that simple squamous epithelium is very good for gas exchange. Now notice the alveoli are cobwebbed with pulmonary capillaries here because that exchange is a two-way street, right? Gas exchange is between the air in the alveoli and the blood in the capillary. So all my alveoli will be covered in capillaries. All my alveoli will also be covered in elastic fibers. So when we breathe in, these elastic fibers stretch, and their recoil is going to be one of the prime things that moves air out. All right, so I got an alveolar sac right here. I see a lot of cut open alveoli, including a couple cut open alveoli right here that I've put a little yellow square on. I want to zoom in on those alveoli. And I've zoomed in on some cut open alveoli. So this is a cut open alveolus. Up here, over here, over here, over here. These are all cut open alveoli. And as I look at it, what I'm seeing here are primarily my simple squamous alveolar cells. So this is a simple squamous alveolar cell. He's called a type 1 alveolar cell. I can also see a simple squamous cell right here. I'm drawing a purple line on him. That is a simple squamous alveolar cell. Here is another one right here. All my simple squamous cells are called type 1 cells. Type 1 cells are where gas exchange is taking place. So oxygen is moving from the air in this alveolus into the blood in that pulmonary capillary. And then CO2 is moving the other way. Okay? So type 1 cells are the simple squamous cells where gas exchange is taking place. I also have some other cells called type 2 cells. This is a type 2 cell right here. Here's another type 2 cells. Plenty of type 2 cells here. They are going to have a different job. We're going to come back to them later on. The third cell type that I have that I got to be aware of are these alveolar macrophages here, also known as dust cells. They're patrolling the alveoli, looking for particles to engulf. Okay, what I want to do now is zoom in on this type 1 alveolar cell right here. See the simple squamous cell right here? I'm going to zoom in on it, plus I'm also going to zoom in on the capillary as well. So I want to zoom in on this exchange area here. So let's go ahead and do that zooming. And there I've done it. This is my type 1 alveolar cell right here. Simple squamous. Air would be inside my alveolus over here. Here's my capillary simple squamous epithelial cell right here. Blood in there with my red blood cell. And this combination of these two simple squamous epithelial cells, plus a little bit of connective tissue between them, that is known as my respiratory membrane. And that respiratory membrane is my exchange area. It's what the oxygen and the CO2 are going through as I'm exchanging those gases. Notice that oxygen is going from the air in the alveolus to the blood in the blood vessel, CO2 from the blood in the blood vessel to the air in the alveolus. And of course, remember that gases are going to go down their pressure gradient. So there is going to be a high PO2 in the air, and then there is going to be a low PO2. Let me erase that. Let me make a big PO2. There's a high PO2 in the air, and then a lower PO2 in the blood. And that's why oxygen goes that way. Similarly, there is a high PCO2, pressure of carbon dioxide in the blood, and a lower PCO2 in the air. And that's why CO2 goes that way. All right. And with that, we are progressing. We got to do one more anatomical thing. We got to talk about the double-layered serosal membrane covering each lung. So each lung has a double membrane. We see the two membranes here in this picture. Here's the lung tissue, and there's two membranes around it. They're serosal membranes, so they're nice and slippery. The inner one is called the visceral pleura. The outer one is called the parietal pleura. And in between there's a pleural cavity. And inside that pleural cavity, like in that pleural cavity, what would we find? Of course, we would find pleural fluid in there. We would find pleural fluid in there. Okay, with that, what does that pleural fluid do? Well, it is going to be a lubricant. So it's going to help the lungs slide against one another. And I see my visceral pleura right there. So Here's another pair of lungs. The purple is my visceral pleura. The blue is my parietal pleura. Pleural fluid is in between there, and the pleural fluid helps the lungs, not experience friction as we inhale and exhale. But one of the other things the pleural fluid does is the pleural fluid is going to cause these two membranes to stick to one another. The analogy I like to make is a glass on a glass table. If we spilled some water in between the glass and the glass table, it would be easy to slide the glass left and right, but it would be very hard to pick the glass up. So these two membranes are going to be stuck together. And what that means is whatever I do to my thorax, I'm going to also do to my lungs. So like if I make my thoracic cavity bigger, because the membranes are stuck together, the lungs are going to get bigger too. So I'm basically coupling the motion of my thoracic wall to the motion of my lungs. Whatever my thorax does, my lungs do. If my thoracic volume goes up, my lung volume goes up. If my thoracic volume goes down, my lung volume goes down. So two big functions of my pleural fluid, which is in my pleural cavity. Okay, let's shift gears a bit and talk about some pressures. Three pressures we got to be aware of. Atmospheric pressure, which is the pressure of all the air around us. Typical value, 760 millimeters of mercury. Then we have the pressure inside the lung, which is known as intrapulmonary pressure. In this particular instance that we're looking at here, the pressure inside the lung is also at 760. So at this moment, there is no air moving in nor out of the lungs because these two pressures are the same. Another pressure we got to be aware of is pressure in the pleural cavity. That's called intrapleural pressure, and it's at 756. Notice that pleural cavity pressure, intrapleural pressure, is less than intrapulmonary pressure. This is really important. So we got to remember the lungs are elastic. So the lungs are always stretched. The lung here is stretched right now because there's air in it. And because it's elastic, the wall of the lung wants to go inward. So the natural elasticity of the stretched lung means the lung wants to go inward. It wants to collapse because it's stretched, because there's always air in it. Now, do we want this guy to collapse? No. And in fact, it is this pressure difference here. The fact that lung pressure is always bigger than intrapleural pressure is going to help me prevent the lungs from collapsing. So pressure inside the lungs is 760 right in here, 756 in my pleural cavity. So air in here is trying to get into that cavity. Air molecules are trying to get into that cavity. They can't because they're just running into the wall of the lung, but they're trying to get in that cavity. And in doing so, they're preventing that elastic recoil of the lung. So, got three important pressures here: atmospheric and intrapulmonary pressures. These are the ones I'm going to look at to know if air is moving in or out. All right, and right now they're equal, so no air is going in, no air is going out. We're going to come back to that as we talk about breathing in and out. But I also got to be aware of my intrapulmonary, my lung pressure, and my intrapleural pressure. And notice that the lung one is always more. What that means is air is always pushing against the wall, trying to get into the pleural cavity. And what's the benefit of that? Well, that's going to stop the elastic lung from collapsing. The elastic lung is always slightly stretched because you always got air in it, and so your elastic lung always wants to collapse. If this pressure difference did not exist, the lung would collapse. Let's take a look at a picture. So here, a disgruntled student stabbed me between the ribs. Why did they have this knife in the classroom? I don't know. And they stabbed me between the ribs. They did not touch my lung with the knife. It was very much of like a hesitation stabbing here. They weren't like fully into it, and I'm happy about that. But when they stabbed me in the lungs, the pleural space, the pleural cavity, air went in there and the pressure in here got high. It was no longer less than the pressure in the lung. And look what happened to the lung. It collapsed to its unstretched size. So this is what happens if we don't have this difference with the lung pressure being more than the intrapleural pressure. Okay. Let's now remind ourselves about something we discussed in lab, which is called Boyle's Law. Boyle's Law basically states that pressure and volume are inversely related. If I look at my container on your left here, I've got air molecules crashing into the walls, creating pressure. As the volume goes down by pushing this plunger down, the volume went down, which means the air molecules are crashing into the walls more often, which means they're exerting more pressure upon them. So as volume goes down, pressure goes up. Okay, this is super important. We're going to utilize this. So to breathe in like quietly and normal, here is what we're going to need to do. Air is only going to move into my lungs if my lung pressure is lower than my atmospheric pressure. So I need to decrease my lung pressure. I decrease my lung pressure by increasing my lung volume. I'm going to increase my lung volume by increasing my thoracic volume. Whatever I do to my thoracic cavity, the same thing is going to happen to my lungs because of that pleural fluid. And I'm going to increase my thoracic volume by contracting skeletal muscles. So certain skeletal muscles contract, my thorax gets bigger, which makes my lung get bigger, which makes lung pressure drop, which creates a gradient, which allows air to go in. So in this situation, notice that atmospheric pressure and intrapulmonary pressure are the same, so no air is going in, nor is any going out. Notice also the muscular diaphragm is in a curved state. That means it's relaxed. When the diaphragm contracts, it goes down. Notice how the diaphragm is now flattened out. Because it went down, my thoracic volume and my lung volume both increased, causing my lung pressure to decrease. Now lung pressure is less than atmospheric pressure, and because we have a gradient, air is going to go in until that gradient no longer exists. So diaphragm contracts, thoracic and lung volume increase, lung pressure decreases, air goes in. Here I see my diaphragm in its relaxed state, very curvaceous right there. Relaxed diaphragm here, contracted diaphragm there. Notice when the diaphragm goes down, the lungs are dragged with it, and the lung volume has increased. So lung volume up here is less than lung volume down here. This is a bigger lung volume, which means in this picture, lung pressure has increased. Now we can also utilize some smaller muscles, but they're not as good as our diaphragm. And these smaller muscles are between the ribs, and they are called the external intercostals. and they pull the ribs up. And so we see here's the normal anatomical state of the rib down here. External intercostals pull the ribs up, analogous to like a bucket handle going out. And when the bucket handle goes out, look how the like left-right dimension is increasing. Like when the ribs are going to be lifted, the left-right distance of the thorax is increased. So my thoracic volume is getting wider, which means my lung volume is going to get wider. And of course, lung pressure is going to go down. Okay. The nerves telling those muscles to contract are also quite important. The intercostal muscles are controlled by our intercostal nerves. The diaphragm is controlled by the phrenic nerve, which I see here coming off my cervical plexus, going down towards the diaphragm. All right, so that is what's going on with quiet breathing. What if I wanted to do some forced inspiration? Like if I want to take a bigger breath in, well, that means I'm moving more air. If I'm moving more air, I need an even bigger pressure gradient, which means that lung pressure needs to be even lower. That way I can have a bigger pressure difference. To get lung pressure even lower, I need lung volume to be even bigger, which means I need thoracic volume to be even bigger. Well, how do I achieve this? Well, first of all, I can use more motor units. Like I can activate more muscle fibers in my diaphragm. I can activate more muscle fibers in my intercostal muscles, my external intercostal muscles. I can do a bigger contraction with those muscles. If my diaphragm contracts harder, it'll go down more, and there'll be a bigger volume above it, and therefore lower pressure, and therefore more air movement. Same thing for my external intercostal muscles. Now, additionally, I can call other muscles into play. I can use this little chest muscle, which I know you remember from Anatomy 1. That little chest muscle is called, let me give you the initials. Can you figure it out? PM. It is the pectoralis minor. That little chest muscle is the pectoralis minor. And notice how the pectoralis minor goes from the coracoid process of the scapula up here and grabs onto ribs 3 through 5. It pulls the ribs up. Think about the ribs coming up, making your rib cage bigger, increasing volume, which means pressure is going to go down. What do I see here? This big strap-like neck muscle. This is the sternocleido. It's one word. I'm just putting it on 3 lines here because it's long. Sternocleidomastoid. When it is anchored on the mastoid process up here on your temporal bone, and it reaches down and pulls on the medial clavicle and the manubrium of the sternum, and it pulls them up. Think about the very top middle of your chest like rising. Think about your sternum like coming up and out. And that's also going to help increase your thoracic volume. Now, lastly, we got these long muscles, deep, long back muscles. These deep, long back muscles are known as the erector spinae. That says erector, E-R-E-C-T-O-R, spinae. And the erector spinae, what they are going to do is straighten your vertebral column. Now, wait a minute. What's that got to do with anything? Well, do me a favor. If you're sitting down right now, sit up like really straight. I just sat up really straight. I got no camera on, so you can't even see that, but I did. Trust me, I'm not lying. And when you sit up really straight, or if you're standing, stand up really straight. Get as straight backed as you can, and you should feel your chest expand. So like straightening your back out actually expands your chest, which expands your lungs, which lowers pressure. So if I bring these other muscles in, I can achieve a greater change in thoracic and lung volume, which means I can achieve a lower lung pressure, which means I can breathe in even more. All right. So that is forced inspiration. Let's do quiet and forced expiration, then we'll quit this video and save the rest for part 3. During my quiet expiratory process, those nerves, the phrenic and intercostal nerves, are going to stop firing. When they stop stimulating the diaphragm and external intercostals, those muscles are going to relax. Diaphragm goes back up, ribs go back in. Therefore, thoracic volume decreases. Lung volume decreases, lung pressure increases, and air goes out. Notice I didn't contract any muscles here. And all this is going to be assisted, well, not all this, but this part especially is going to be assisted by the elastic fibers. Remember, we got that elastic recoil. That elastic recoil is going to assist in that decrease in lung volume. That's why those elastic fibers are quite important. So that is my basic quiet expiratory process. But let's take a look at a picture of it. So right here, we're in between breaths. So previously we had breathed in. We're about to breathe out, but we haven't done so yet because the pressures are still the same, okay? Notice the diaphragm is contracted. It's flat. So what the diaphragm is about to do is about to relax and go up. And here the diaphragm has gone up. It has relaxed. When the diaphragm has gone up, the thoracic and the lung volume have decreased. The recoil of the elastic fibers have helped with that. They don't recoil all the way because we still have this pressure difference right here. But because of the decrease in volume, pressure rose. Notice it's now 761, higher than atmospheric, which means air is going to go out. And that's my basic quiet expiration. Now, what if I wanted to take like a big, huge breath in? I gotta move more air, which means I need to have a bigger gradient of my pressure, which means I need to make my lung pressure even bigger, which means I need to make my lung volume even smaller, which means I need to make my thoracic volume even smaller as well. And how do I do this? Well, I am going to utilize muscles, particularly abdominal muscles, my rectus abdominis, my transverse abdominis, my oblique muscles. All of these muscles are going to compress my abdomen. And if I compress my abdomen, I'm squeezing the organs in there, especially my intestines, my stomach, and those organs are basically pushed upward and they smack into the diaphragm and they push the diaphragm up. And if you push the diaphragm up, well, the thoracic volume is going to get smaller, meaning the lung volume is going to get smaller. So contracting all of these abdominal muscles is going to help you breathe out, because by compressing your abdomen, you're going to push up on the diaphragm. We also have internal intercostals, which are going to pull the ribs in. If I pull the ribs in, my thoracic volume gets smaller, which means my lung volume gets smaller, which means my lung pressure increases. So if I'm trying to, blow out a candle, blow up a balloon, I'm going to use my abdominal muscles, plus I'm going to use my internal intercostals. All right. On that note, we're going to pause right here. We'll pick up with a discussion of airway resistance in the next video. We'll finish up this whole respiratory system next time as well. Okay, see you later.